Good morning, everybody, and welcome to HMR's Primary Care Commissioning Committee for April. I'll just do some welcome and introductions. I think everybody knows each other on the meeting, but Nicola, I just wondered if you wanted to introduce yourself, just because it's new and we're on YouTube.
Yes, I'm Nicola Thompson. I've taken the role as Director of Health and Care, DAS for Rochdale Borough Council Adult Social Care, and Deputy Place Lead for HMR. I'm delighted to be here. Thank you.
Thank you. Welcome, Nicola. So straight into the agenda. Do we have any apologies, please?
No apologies received, but Steve Rumbelow has not joined the meeting yet.
Thank you. Thanks, Stacey. Any declarations of interest anybody wants to raise? No? Okay. In terms of the minutes from the previous meeting on the 10th of February, has anybody got any queries on the minutes? If so, please, can you let me know? No? If not, we'll take them as an accurate record of the minutes from the previous meeting. In terms of actions, there are two open actions. One was to share comments about the blueprint with Sarah Crosley, which has been done, and the blueprint is on the agenda today. The second action was to provide an update on how the PMP slots are being filled and allocated, and this was done outside of the meeting, so that action can be closed too. So no actions to carry forward. In terms of Chair's actions, there haven't been any over the past 2 months, so there's nothing to update. So we'll go straight into item number 6, please, Sarah, which is the access update. And just to note, this is for decision by the group. Thank you, Sarah.
Thanks, Jonathan. Yeah, morning, everybody. So I'll just do a quick overview of the paper because you've all got the paper in front of you, hopefully, and most people have had a chance to look at it. So it's a paper of 2 parts, really. So part 1 is just an update on the HMR delivery to date under the new PCN contract DES for enhanced access. And the second part is the part for approval, which is where we're asking the committee to review a number of options outlined regarding the direction of travel for the enhanced primary care hubs and the consolidated Sunday and bank holiday service for 23-24. So just to draw the committee's attention to a few points around enhanced access, for those of us who can remember, that was a contract change, which meant that we had a change in how our services were being delivered from the 1st of October. So that service has been running now for 6 months. It's a national mandated service as part of the PCN contract DES. And as part of that contract DES, there are specific service requirements for the time at which that enhanced access is provided. So it had to be provided between 6:30 and 8, Monday to Friday, and 9 to 5 on a Saturday. And it also prescribed the capacity. So the HPCN had to deliver 60 minutes additional appointment time per 1,000 PCN adjusted population. So there were lots of formulas and lots of calculations done around what that would mean. So what this paper is asking the committee, is updating the committee, is that as part of that contract, there is a role for the commissioner to monitor delivery against those service requirements. And there are sanctions provided in the contract up to withholding payment if there's been any issues with that service delivery. So I think the committee will remember from the time we had a very short time in which to mobilise these services, and we've worked really hard with the local providers, and we continue to work really closely with them because the services has been challenging to set up, not least with some of our estates challenges in our practice across HMR with some of our locations. So what really wanted to update the committee was the GM are starting to develop a combined process now across all 10 localities around how we're going to develop a fair, consistent and transparent approach to manage any under or over service delivery, any discrepancies against the delivery against the contract. So we have had some issues with under delivery across 3 of our PCNs in HMR, which the indicative data, and it is only indicative data at this point, looks like we've under delivered by 500 hours across 3 of our PCNs. Now, this has been down to our estates because we've not had the volume of estates to be able to deliver those services across there. So that work is continuing. We have already put mitigations in place, and that estates issue is resolved now. So we've got some extra capacity at a different place. So we're not anticipating that that would be a recurrent problem with under delivery against the contract for next year. But it's just to make the committee aware of that, and then to update around the fair and consistent process and how that will be managed across the 10 localities now across the GMICB. So I will pause and take any questions on that bit here, if that's all right, Chair, and then we'll move on to the part 2, which is the bit that we need approval for. So that was just really to update the committee on actions that we're taking and the position we're in across HMR at the moment.
Thanks, Sarah. Anybody got any questions on part 1 of that paper? Sorry, it won't click off. Sorry, someone's raised a hand. It won't click off for me. Kate, sorry, it won't click on for me.
Thanks, Jonathan. It's Kate. Just to introduce myself, sorry I was a bit late coming on the call. My name's Kate Jones. I'm the Chief Executive at Health Watch Rochdale. Thanks for the paper, Sarah. I think something I just wanted to raise, and it's not in regards to the decision that's made today by the committee. Within the paper, it talks about stakeholder engagement, and I'd be interested in a little bit more to understand what that stakeholder engagement was. I think in regards to the uptake of the service and the stats that were provided, I found that really interesting. If you remember, Sarah, in October 22, we went out and sorry.
Yeah, sorry to interrupt, but that's talking about the part 2 bit of the paper. So it's not about the enhanced access stuff, because it is a paper of 2 parts. So
yeah,
the stats provided. Yeah, no, is that all right? Yeah,
yeah, totally understand that. So it was just to say that in October 22. Both the CCG and Health Watch independently went out and engaged with patients around, you know, sort of like that extended service, and it was 40% of our findings and didn't know what this service was. So I think for me, it's just really to put out there straight away the fact that no matter what the decision is from the committee today, and I'm not a decision maker, you know, in that. It's the fact that people don't know about the extended services. Our key data that's coming through is that people cannot access GP appointments. And like I said, 40% of our findings from a survey in October 22 showed that people don't know what this service is. So I think when I see the stats of, you know, the uptake of the service, I find that difficult when we know GP access is such a big concern. So for me, I'd really like to just push the fact that communications, whatever the decision is made, really need to go out. People need to be informed. And I think, you know, there's more reassurances needed from GP practices and their staff to say that they are signposting on, because all we hear on the ground from patients is that they are not signposted. So I just really wanted to emphasise, like, away from the decision making, we need to publicise what this service is, and we need to make it, you know, extended services means nothing to the population. Actually, this is, you know, how do you want to visit your GP out of hours? So I think we really need to think about the terminology, and we need to concentrate on communications to the residents to empower them to be able to, you know, go and make those appointments at extended services. So sorry to raise that, because, you know, I've got the statistics, and I think we've done the work to show that it's not utilised, and we know that.
No, it's a fair point, because like you say, part 2 of it is, it's almost a decision of what's next. So which one is the preferred option to then do some more work around. So it's really important to raise that, Kate, that whatever decision is made today on how it will look, one of the key pieces of work has to be communication with the local population, so they know what it is, know it's available. And I know you've raised before about the access to primary care. So the fact there is an enhanced service out there, we really need to make sure our residents are aware. So it's a fair point. Any other questions on part 1 of the paper before we dip into part 2? No? So if you want to go through part 2, and again, just to raise with the group that this is about a decision to then scope and undertake which one we choose today. So out of the 3 options.
Thanks, Jonathan. Yeah, so part 2 is talking about the enhanced primary care hubs and our Sunday and bank holiday service, which are another way of contracting enhanced access out of hours for our GP practices. So the enhanced primary care hubs were commissioned, but they provide in-hours capacity as well as out-of-hours capacity. So they were set up initially in response to some significant winter pressures. So at the last committee, we brought forward the full evaluation of the enhanced primary care hubs as they have been running throughout 22-23, and also an evaluation of the Sunday and the bank holiday service, which we had commissioned to plug the gap, if you like, with some of the contract changes, which is around the national enhanced access services, which left us with a gap on our Sunday and bank holiday services, where historically HMR residents had access to urgent and routine GP appointments on those days. So we agreed that we would commit to continuing those services in 23-24, but we wanted to deliver a consolidated service, and recognising some of the points that Kate raised earlier, it is very confusing with the terminology and the different services and stuff. So this is a proposal about how we consolidate those services, and we'll be able to deliver more effective comms to the population around that. So what the paper does is take you through outlines three options, and the main focus is on what our core operating hours should be for that consolidated service going into 23-24, because throughout 22-23 they've operated at different times, and as we've tested out different models and different different demands and pressures have been faced on the system. So that's why there's a brief analysis there of the utilisation rates for the different times those hubs have been open, and the different operating services on the Sunday and the bank holiday service. So the recommendation in the paper is that we approve option 3, which is the core operating hours from 12 p.m. till 6 p.m, Monday to Friday, and the Sunday and the bank holidays is a change, so they would open 8 till 4. And that is the proposal, recognising that with the other enhanced access service that we have in place, we have a 9 to 5 service, which does routine and urgent general practice appointments on a Saturday, and that's offered a range of hubs across the sector. So I'll pause there and see if there's any questions around this, but we recognise that this is an approval for the direction of travel for those operating hours, and further work will be done to work up that model, recognising some of those points we've raised earlier already around the clear comms and engagements of the public around that, and that would include the financial costings as well for that model.
Yeah, thanks, Sarah. A good reminder to the committee of what we're actually deciding today, and to say some of the analysis done and how well utilised it is, and then the comms piece. Right, I've got two hands. Steve Rumbelow, please.
Thanks. Yeah, I came in late to Kate's contribution about comms, and clearly there's something about comms. However, I don't really see how the data in the report supports option 3. As colleagues will know, I was absolutely adamant that as a result of the new DES, we did not withdraw 7-day access because it was being used. But actually usage just seems to have dropped off a little bit, and none of the months that are in the analysis get over 50% utilisation. So we can't just go ahead on that basis. And I know one of the considerations is, I think it was Dr. Jeever at the time, raised concerns that if we reduce the hours, it makes it harder to get GPs to commit to it. Now, if that's an issue, we need to discuss that issue. And that's not mentioned in the paper anywhere. So I'm sceptical about moving forward on option 3, because I suspect the comms issue relates mainly to the weekday service, even though the utilisation is pretty good. There's clearly capacity in that. It's up 70-80%, occasionally 90%. So it's good. It's good utilisation, but there's clearly a little bit of extra capacity. And whilst it's really important we give access, it's also important that we're efficient and effective in how we do that. And utilisation at 30-40% and then a proposal to extend the hours makes no sense.
Do you want me, can I come back on that? But Greg's got his hand up as well, so I don't know whether, Greg, would you want to come in, because you're a bit closer to some of the data analysis and some of the figures that went in there.
Yeah, so just on a couple of points that were made, the figures that you see for the Monday to Friday, it's really important to note that they are just for same-day emergency GP appointments. They're not for routine appointments. So in terms of the public trying to get access, those appointments are ring fenced, some for UTC to get streams from there, but also for that same day emergency, they're not routine. We move into the Sunday, they are a mixture of routine appointments and same day appointments. And I agree, the utilisation isn't as good as it could be. But then there's that question about, well, what hours would we do? Would a GP want to work a shorter time for it to be more utilisation? So I guess that's the debate we're going to have now. But I just thought it was important to note that the majority of that data is for that additional same day GP appointment, which we put in extra over the winter months when we know we see periods of increased demand.
Can I just come back briefly on that, Greg, if I may? I mean, I get that. I think my issue really is, if we are doing this because because otherwise we wouldn't get GPs to work those shorter hours at a weekend. I get that, but it should be the discussion, and that's not featured in the paper. So it looks as if we're taking a decision based on utilisation rates that are low to extend hours, and it just, we can't be seen to be making a decision like that, because it looks nonsensical. And I don't, and you in terms of, I understand that the weekday hubs is about urgent appointments, not routine, but actually they take pressure out of the system, and that was what they were designed to do. So take pressure out of the routine GP appointments, because otherwise GPs are seeing people, would be seeing these people anyway, a lot of them anyway, and also to obviously to help us with patient flows in terms of the UTC. So that's all sound, and it's great that that's working, and that we've got a little bit of extra capacity. And coming back to Kate's point, we need to make sure that people know that access to emergency appointments is there. But none of that supports what this part of the paper is suggesting in terms of Sunday and bank holidays. And we all know that patients are people, aren't they? So the reality is that if it's urgent, they're likely to utilise an appointment on a Sunday or a bank holiday. But actually, if it's more routine, then they'll probably wait, because that you've just got to accept, haven't we? That is human nature. You know, we put our families first, ourselves first, even above our health sometimes.
Okay, so I think what we're saying is we can't make a decision out of those three options without some more information. So Sarah, I wonder if it's worth scoping the three options in a bit more detail and bringing that back.
Yeah, that's fine. There have been some technical issues, I think, with extracting some of the detail under the analysis of those, but I think particularly looking at the Sunday and the bank holiday service, then that would be really helpful to get under the skin of that. There is an ongoing evaluation in the use that's been conducted by Health Innovation Manchester as well across the patch with the ARI hubs, which are hubs fit that definition of, and that work should be completed at the end of May, June, I think is the anticipated time for that as well. But yeah, we'll definitely do that and do further analysis, so we can bring that back to the Sunday and bank around the issues around the Sunday and bank holiday service, because I think we do have that analysis for the in-hours hubs Monday to Friday, don't we, as we've said, which we know is taking the pressure off the rest of the system.
I'd sort of gone about it, but I think if we do come back to the point that getting GPs to work those shorter sessions is a problem, yeah, the solution might be to look at whether if they work in a shorter session, they get a bit more money for it. That will probably still save us in the long run.
Yeah, absolutely. And I think that's the further work we can do around the costings, which we needed to. So we wanted to inform the direction of travel, because we'd obviously had a variety of hours of operating models, a variety of models with different operating hours. But yes, we can do that further analysis, and then that costing work will absolutely support that, Steve. So we will have a range of options then that we can bring back, can't we? And we can make a decision around which is the most resource and cost effective model for us to commit to for 23-24.
Absolutely. And don't get me wrong, it's clearly a service that is being used, and a service that we ought to be looking to retain, but we ought to be looking to sort of make sure it's really sort of maxing out on the advantages.
Absolutely.
Okay, so action is to do some further work, bring it back, and provide some costings to go with it. Okay, Greg, would you like to take us briefly through the risk register?
Sure, can, yes. So the
Timeline.
risk register is attached for information. Just a couple of highlights to point out. The demand, as we've just discussed in that paper, and workforce, which I'll get into in my next paper, continues to be the key risks within primary care. But as we've just been through with Sarah, we've got the hubs and the enhanced access, more work to be done on that, which supports that demand risk and mitigates some of it, as well as workforce and wider workforce across health and social care as a whole. It is still an issue, but as we'll get into in my workforce paper, there's some bits to share about what we're doing about it there. But other than that, there was no changes to any risk scores or anything to come off or to go on. So that was my risk register update.
Okay, thanks, Greg. So we'll pick up in the workforce in the agenda item 9. Sarah, do you want to feed back on the blueprint update, please?
Yes. Thank you, Jonathan. So this is just a verbal update for the committee. So as you may recall, we brought the scoping document for the blueprint. So for those of us, I think everybody is probably up to speed with it, but the primary care blueprint is a document that's been developed across GM. It's been led by Rob Bellingham, the Director of Primary Care at GMICB. We shared the scoping document and the approach at the last committee. So I just wanted to update about the work that's taken place since we last met. So through this triumvirate leadership approach, which is a representative from a locality, a provider rep and a central GM team rep, each of the chapters have a leadership team, and they've been going out and developing an engagement document. So some preliminary engagement has obviously been undertaken with areas and different providers and different functions across the system to inform that engagement document. But the purpose of the engagement document is obviously to start the engagement proper. So that document is due for release today. So there should be something that comes out to you all after this meeting around that. So that's just going through its final proofing and typo check, I think, with Rob and his team at GM, and then that will come out. And I think really the important thing is how we as a locality can shape and influence then the final product, which is going to be supported by this engagement framework, and how we inform those deliverables. So I think, as Rob would say himself, that what the focus is, it's neighbourhood, locality, then ICB in that order. So it's really important that localities get the opportunity to feed into the shaping of that blueprint document, which will hopefully at the end of it will give us a prescription, if you like, for the things that we're wanting to do to improve quality and efficiency of services across primary care, across GM. So there is a whole engagement plan being worked up, and it was just really to update the committee on that and say that we'll share the document with you as soon as possible. I know the engagement has started with Rob attending our locality board earlier in the week doing that. So there's 4 key bits that are still being developed alongside the engagement document now. One of those is an investment plan. The other thing is further work on so it's data driven and the outcomes are really clear, and then there'll be obviously a delivery plan that's developed. So that is going on parallel while this engagement work is going on, and then with the aim that there'll be I think Rob wouldn't call it a final document, but because we recognise that things are going to keep moving. So because we're still awaiting some of the national documents that are being released, not least the National Recovery Plan for primary care as well, which is now due to be published hopefully mid-May. And it will be informed by all those things, but it is going to be an evolving document, but it will set a direction of travel and a delivery plan for the next 1 to 5 years for GM. So it's just a plea from everybody to read those documents when they come out, and then we'll be in touch with further engagement about how we can influence it from HMR locality.
Okay, thanks, Sarah. Thanks for the update. It was really helpful to have Rob come to locality board on Tuesday, so we could raise some questions. Any questions for Sarah on that item? No? Okay. Greg, do you want to move on to workforce, please?
Yeah, so workforce update mainly around the ARIS to begin with. The table shows the end of year position for PCNs and their spends against their ARIS allocation. It's important to note that total underspend of around 900k is noticeably higher than what we saw in February, and this is for 2 reasons. We had a HMR pilot we put forward to GM for health and wellbeing coaches across the entire locality, which was rejected because we wanted to use some of the underspend on a borough-wide approach to health and wellbeing coaches. That was rejected, and also the forecasts in February were just that. They were just forecasts subject to successful and timely recruitment from our PCNs. There was a lot of movement in the bridge, for example. They were showing an spend of about $250,000, but they've come right down in this past month. And we continue to work with the PCNs who haven't completely spent up to get them as spent up as possible. There have been some changes to the Irish roles to notes with 23-24, things like increasing caps on advanced practitioners per PCNs, reimbursement for first contact practitioners to undertake training to become advanced practitioners, which wasn't there before, apprentice physician associates, and removing caps on mental health practitioners by PCN as well. So these things will help our PCNs recruit into these roles and have more of these different types of roles moving forward, which helps with their spends. So also important to note, 23-24 is the final year of the PCN contract days. NHS have confirmed that staff employed through Iris will be considered core general practice moving forward. Therefore, PCNs can begin to appoint on permanent contracts moving forward where appropriate. We then have the table for our 23-24 allocation, and work continues with our PCNs as a primary care academy to ensure our PCNs spend their full allocations. As these, as I mentioned before, these will go into the practice baseline, practice income baseline for 24-25. In terms of other work going on in primary care and all things workforce, we continue to work with the Primary Care Academy to build up our own workforce and develop our own workforce within primary care, including things like beginning to work with local universities and colleges to have summer placements for students, supporting our current workforce with their continuous professional development, as well as contributing to the GM Workforce Blueprint. In addition, the Primary Care Academy and key stakeholders on the primary care team as well are part of the Locality People Committee, which leads on borough-wide, sector-wide workforce. And this group has contributed to the People's Strategy within the LCO business plan, which is attached for information. Happy to take any questions on that.
Thanks, Greg. So a couple of comments. I think it's really useful and timely that they've nationally have started to give PCNs a bit more bandwidth on who they can appoint and how the roles fit. It's been so narrow, it's been difficult. Just a question from me on particularly Rochdale North, given the substantial underspend this year and the substantial amount next year. Can we, or have we got an actual work programme with them of how they intend to spend that 1.4 million? Because that's a lot of recruitment in year. If we haven't, I guess the question is, can we get something together that says this is what they're planning to recruit to spend that 1.4 million?
Yeah, so
we just look a massive outlier.
They do, and part of it is that it's so vast it's going to look a big underspend, isn't it? But also we have been working with them to develop this recruitment work plan, which some of it was in place, but timescales on that just need to be more tighter or stringent, or more communication with ourselves to understand those timelines moving forward. But that work does continue in the background, and if all things had been successful in the past sort of 6 weeks, we would be at a less of an underspend than what we are now. But it's just continuing to work with them to get where they need to be. And that's something we should be able to bring back at future committees, that more clear timeline-based recruitment.
Yeah, I was going to say it'd be helpful. Obviously, you do keep this committee updated, but I think it'd be helpful going forward just to see where they are and where they are on the work programme. Steve.
Thanks, Jonathan. Yeah, really helpful report, Greg, really sort of thorough, a bit alarming. Just to clarify for me, really, in terms of, so the spend will be embodied in the core contract, essentially, in the core funding. And when will that happen? Will there be a guillotine? So if they've not, will it be embodying what's already committed into the bottom line, and anything that's not committed, will we lose that from the system?
That is a good question. So the way it works is, so we wouldn't lose it from the system per se, just their final baseline at the end of the contract days would be lesser than what it could be. That's not the greatest explanation, but it is very complex.
Yeah, but so what will happen with the money? So it strikes me that suggests there is a risk that we lose it from the Rochdale system. It might go elsewhere.
Yeah, there is that risk. Yeah, if they're not fully recruited by the end of 23-24 up to those thresholds, that it won't go into their baseline at the end of 23-24 is what we're led to believe. The final detail is still awaited, but that is the principle that we're all working on, which is why there's a real absolute push and focus now on supporting the PCNs to get everybody in post as soon as possible, and managing any accruing underspend, because every day that we've not got somebody in post from the 1st of April, that underspend is accruing, to make sure we've managed that at a locality level, to make sure we've drawn down those resources as much as we can, to make sure it's protected and it's in practice baselines at the end of 23-24. Some of our PCNs are very focused and very on with that. There's a couple of others that need a bit further dedicated support. So I did put my hand up to come back on that. So those PCNs, they have got recruitment plans in place with RHA, who are managing their recruitment on their behalf. And that's what we'll be able to bring back to the committee in future, those detailed recruitment plans with the planned recruitment engagement and when we're hoping to have those people in post.
Right, so we are putting the support in to try and help them do that, and it's looking okay at the moment. Okay, we just need to keep on top of it. I mean, we just need to avoid presiding over a situation where primary care services end up losing money, and recognising there's a whole different issue about bringing these other this other part of the workforce in and managing the risks around that, and making sure that people are trained up effectively and are contributing. But fundamentally, I think we all accept that it means that GPs can do doctoring, and people that and the staff that you're bringing in can do all the signposting much more. Relates back to what Kate was saying earlier, really, doesn't it? That if the more people we've got that can do that signposting effectively, means that GPs themselves are not having to do it, and they shouldn't be doing it. Okay. Just one further question, Greg. You said on the borough-wide initiative that we put forward that was turned down. Who's holding the decision-making on this? Is it the ICB or is it NHSE still?
It's NHSE.
Right.
And it's really stringent about, like what Jonathan said in his introduction around how stringent they are and how some of these new changes do allow a little bit more recruitment, but it's still very, very strict in terms of what you can claim for.
Right. So
anything outside the box thinking doesn't really go down well in this contract test.
Yeah, we just need to be a bit clever around it, then, don't we?
Yeah, we don't want to lose money out of the system, particularly with the issues that Kate raised before. So I think it's really important we keep an update and have some sort of work plan, but it's good that we're supporting them. Any more questions on this item? No? Okay. Sarah, can we go on to Core Plus, please? Item 10.
Yeah, thanks, Jonathan. So yeah, everybody's got the paper. So just a very brief overview. There's a bit of an update on our look back for 22-23, and we know that the committee has been involved previously. We know there were significant winter pressures which did limit some of the ability to deliver, and we did suspend reporting in Q3 for Core Plus last year. But they did submit the year-end reports, and we are working through those now, but they acknowledge that there's been some gaps and they will be picked up in 23-24. The main focus of the paper is really, and this is what we're asking for the committee's approval for today and support for, is to endorse the outlined approach for 23-24. As you may recall, we did a big review over quarters 3 and 4 of Core Plus, because it was a new idea 3-4 years ago when it was first incepted, and then it worked very differently over COVID, and then we've reinstated it. So the outlined approach is in response to the feedback we got from that whole scale review, and the paper outlines the sort of set of principles that we established from the feedback from that review, and highlights 4 key changes that we're proposing to Core Plus for 23-24. So those key changes is a reduced number of indicators. For those of us who've been around a while will remember that there were in excess of 78 separate indicators, and then even under that, different subsets of reporting from the first iteration of Core Plus. So we did get a lot of feedback in the review around a simplified and a simplified and reduced number of indicators would be welcomed. So I think we have, there's a proposal, and as you can see in the appendix, there's a bit more detail around what there would be, but we are hoping to have no more than 25 indicator areas. That's the proposed approach for this year. One of the other key changes is the introduction of a new population health outcomes indicator area as part of our quality and performance section. And that would signals a real outcomes focused approach, so how we would drive up and improve clinical outcomes for patients on a neighbourhood footprint. The work is taking place throughout Q1 to develop exactly what that would look like, because there's a sort of a picky list of menus, some areas that we might want to look at. The data is being collated for that now and looking at it on a neighbourhood level, and that work will take place throughout Q1 with a range of key stakeholders to determine how we want to focus our efforts, and whether that is that one neighbourhood might focus on diabetes, for example, because that's what the issues are in their neighbourhood, with contribution from the neighbourhood teams and being data driven. Another area might, for example, have more of an issues around asthma. But how that's going to work and how that's worked up is part of the work that's ongoing at the moment throughout Q1, because there's all different input from our public health consultants and opportunities around that. So there may be a different range of options there, because actually we might be better focusing on diabetes across the patch, but having a different approach taken by each neighbourhood, because they're informed and got different needs and different demographics from their population. But that work is commencing throughout Q1 with a plan for implementation and specific targets at a neighbourhood population level to be put in place for the remaining 3 quarters of the year. The other key change is we're to keep the incentive payment element. For those of us who remember that we had what we always refer to as the Bloom payment, but it's the incentive element of the scheme, and that used to be 30%, but the proposal is that now reduces to 10%, and will be tied to the submission of the returns and the monitoring and the quality of those returns that we get in to demonstrate our achievements against all of those indicators. And the other key change is the development of a separate medicines management incentive scheme. Historically, that was included, and Core Plus was a very wide-ranging, all-encompassing incentive scheme, but the proposal is that that's developed separately and worked up separately. So the only other thing I have to highlight everybody's attention to is the current position. So because of the contracting year, the principles and the key changes that were informed from the review were taken into contract negotiations that commenced in February. So they were successfully completed, and the financial envelope for 23-24 has been agreed. And what we're asking the outline approach, has also been taken to the LCO board. So we had a good discussion there around it, and especially around the new population's health outcomes focus at a neighbourhood level. And they were supportive of the approach, so that is included in the paper as well. And we are asking the committee here today to review and take comments and hopefully approve our outline approach for 23-24. Pause there, Jonathan, if that's okay.
Thanks, Sarah. That's a 5-minute wrap up of an absolutely huge piece of work that's taken months and months. So thank you to you and the team for all the hard work that's gone on behind the scenes. As Sarah said, quite a lot of this has been iterative. So LCO board has been cited, ourselves as execs have been part of this work. So what we're asking for approval today is that this is the direction of travel now for the Core Plus contract. Happy to take any questions. Okay, I will take silence as that is approved by this group. So thank you very much. Damien, finance report, please.
Yeah, thank you very much, Chair. I won't take too much of your time. Obviously, the report takes us through to report primary care at the end of the financial year for 22-23. So this was as we became the ICB, so from July to the end of March. I don't think there's anything that hasn't been reported to PCCC in previous reports. The pressure, you won't be surprised to hear, is still around prescribing and obviously the access to drugs and the no cheaper stock obtainable. There's been a movement in the outturn, mainly due to an increase in the forecast for the no cheaper stock obtainable. As we moved to an ICB, there's been close working across the 10 localities to ensure this consistency on how we forecast. We're always 2 months behind with data for prescribing anyway. But there has been a lot of discussion around consistency and ensuring that we forecast on the same basis. So locality finance leads were presented with a few options around how to forecast for the pressure, which in turn led to an increase in the locality prescribing outturn of 900,000. We did get an additional 1.4 million of budget from GM to cover these pressures. So that has led us to a 212k pressure at the end of month 12, or slight underspend within the local incentive schemes budget, which was prior year benefits, which has led to an overall pressure of 145k within primary care in the locality at the end of month 12. I think it's fair to say that as a locality, we have met our control total, but there was a pressure on prescribing, again, purely due to the NCSO pressure as previously reported. So I'm happy to take any questions around that.
Thanks, Damien. So just as a year-end review, it's a stable position for primary care, slight overspend, but that's been funded within the overall control total for HMR locality. Any questions for Damien? No. Thank you, Damien.
Thank you.
Next report I will take myself, which is the IMT update. As you'll tell by the paper, there's a lot going on in IT with primary care at the moment, but just 2 things to pull out really for this committee. Just to say that Patches is now coming to an end, which is the online digital triage message video consultation that should become BAU. And just part of the conversation we're having before, we're now seeing 2,500 patients per month take up video consultations or online, which is good progress, but accepting not everybody has access to IT solutions, but a good use of resource. And secondly, slightly not an IT issue, but partly is the Milnrow Hub will be opening soon. I'm really positive that 2 GP practices into the Milnrow Hub, purpose-built, state-of-the-art new building will be open in the next week or 2, and we'll be putting some comms out. So happy to take any questions on IT if anybody has any. No. Okay, public questions. I believe we've not received any for this committee this month, so nothing to report on. So I'll just ask if there is any other business. No? Great. Thank you all for attending today. I'll call an end to the meeting. For